We indeed recently wrote a review which will be out in Genes and Development in the next couple of months, focusing on what mouse models can teach us on lung cancer. And so specifically on the different subsets that we can identify in lung cancer. So adenocarcinomas, squamous cell carcinomas, and small cell lung cancer. And so we treat each of those tumors and list what models have taught us, which hopefully will be useful for treatment of human patients. We were specifically interested in what are the early phases of tumor development. The issue is that in patients, by the time they enter into the clinic with complaints, their tumors are usually pretty much advanced. And so we know very little about the very early phases. And that's particularly significant for small cell lung cancer, because that's one of the cancers that has such a bad prognosis that patients are not operated once small cell lung cancer is detected. At least that's very rare. And so as a result, you're only looking at patients then with very advanced tumors. They are not operated. And as a consequence, access to materials has always been very difficult. And especially for what might be the initial phases of tumor development, because that's where you want to intervene possibly. And what you would like to see is what type of markers or indications you might find that could allow you to do early detection and a better prognosis. And that's where we use the mouse models are actually quite useful for. First of all, a mouse is of course not a human. And so what it does, it teaches about biology and how things work. And now the good news is that if we look at the tumors as they occur in mice and in humans, they are really very similar. And so even to the extent that if we look at, for example, immune infiltrations, which is important because many of the treatments now have an immunotherapy basis. So we want to know what type of lymphocytes and neutrophils and macrophages and so on, how they behave in the environment of the tumors. And it appears that that is very different between tumors. And so it appears that the mouse tumors in that regard very much resemble the human situation, even though humans carry many more mutations in those tumors, whereas in the mouse, just a few mutations have been manipulated into the system. Still, the resemblance is enormous. And as an example, the small cell lung cancer is generally considered as a cold tumor, meaning that very few lymphocytes and hematopoietic cells have infiltrated in that system. And that we see both in mice and humans, whereas some of the other lung cancers, like squamous cell carcinomas, they are filled with neutrophils, again, both in humans and in mice. So there is a microenvironment that is rather similar, that attract those lymphocytes and other hematopoietic lineages that are important for potentially immunotherapy. We use different sets of models here, right? So on the one hand, we have this autochthonous model where we have spontaneous tumor development in the mice, and obviously we have the xenografts in which we use transplanted human tumors in mice and see how they behave. And actually each of them have their own specific benefits and advantages. Obviously, when you use xenotransplants, either directly from tumors or from circulating tumor cells that you very efficiently can isolate from the circulation of patients, especially those with small cell lung cancer. I think they provide you different answers. In one case, you can see whether there are specific vulnerabilities that are characteristic for the human tumors, whereas in the case of the mouse tumors, you might have the advantage that you study tumors at their orthotopic location, as well as in a condition where you have an intact immune system. So from both systems, you can learn. From the transplant models, you can learn whether there are specific vulnerabilities against small molecules, for example, whereas in the autochthonous models, it's better to understand some of the rules that are governing immune responses, for example. So we need both. And like I said before, it's the mouse models teach you more about the biology and general principles. And people who say, well, you know, these mouse models are useless because you can cure mice and it never works then in humans. To some extent, they are right. I have to say that we cannot cure these lung cancer mice either. And some of my colleagues have actually sort of provide you with $10,000 if you can cure their mice. So it's not that mice are always easier with respect to cure them. Nevertheless, of course, it's are two different systems, and we have to understand the restriction of a mouse models. Of course, the mouse models are always used as a first stage to see if a particular treatment works. And you know, the sort of sad news is that if we use all sort of combination therapies in mice, actually almost none of them works. And in that regard, a similar situation we encounter in humans. That doesn't mean that therefore the mouse is a good model, since both don't work. But still, it also tells you how hard it is to find proper treatments. And because it's just a very difficult tumor. And that's specifically true for the small cell and squamous cell carcinomas. For adenocarcinoma is slightly different. There we do have, you know, efficient treatments in patients. And in fact, that works also in mice. But so what one tries to do is to find whether new combination therapies might be more effective. And that is going through the stages of start out with cell lines and then try whether that also works in the mouse models. We have done extensive studies in this area with a lot of combination therapies with different drugs that would sort of be predicted to be potentially effective. Unfortunately, these results were rather disappointing, simply because there were not good combinations that would effectively kill these tumors cells even. And I'm not to speak about the spontaneous tumors that arise in the mice. The takeaway message is that we don't have at this moment a very strong new perspectives for treatment. I think there are a lot of options to further explore. That's, you know, better understand how we can make cold tumors into hot tumors so that immune infiltration should become more effective. And I think we can learn from mouse models how to do that, but we are not there yet. And so this is still, to some extent, hopeful. We are hopeful that that might work, but we are not there yet. And many of the combination therapies with small molecules so far have been disappointing. So there is not a very clear perspective that would say, well, here we have a combination, you know, start trying it. And in this regard, it's not so much a message to clinicians, but to people that smoke and that say, I would say, stop smoking, because, you know, small cell lung cancer, in contrast to some of the others, is invariably associated with smoking. And so we can do something about it, but curing is going to be difficult and will take many years before that will be effective. So I think we will learn more in the years to come from the models. I think they are the most suitable system to understand the complexity of the lack of immune responses, or the poor responses. And once we understand that, we might have better inroads in treating patients with, for example, immunotherapy, where at the moment only a very tiny fraction of small cell lung cancer patients profit from that.